Gastroesophageal reflux disease, or GERD for short, is one of the most common gastrointestinal diseases in Australia, with approximately 10 to 15% of the population affected by it. To begin with, when we eat food, it first travels down our mouth, into the esophagus, and then into the stomach. In the stomach, there are secretions made of acid and enzymes to digest the food. However, due to a low pH, these secretions can also damage unprotected tissue, such as the esophagus. To prevent this, at the opening of the esophagus to the stomach, there is a lower esophageal sphincter, which opens to allow food and prevent backflow. However, in GERD, there are more frequent openings of the sphincter, impaired esophageal mucosal defense, and defective esophageal peristalsis, which allow gastric secretions to enter the esophagus, remain there, and damage the esophageal lining. In some GERD patients, this may also be due to a hiatal hernia, where part of the stomach is above the diaphragm. The damage by gastric acids can cause esophagitis, which is inflammation of the esophagus, resulting in the narrowing of the esophagus due to formation of scar tissue, esophageal ulcers due to the acid-damaging mucosal layer, and bleeding of the upper GI tract. Exposure to gastric acid can also cause Barrett's esophagus, where the squamous epithelium layer of the esophagus is replaced by columnar epithelium, which is precancerous and can progress to esophageal adenocarcinoma. The most common symptoms of GERD include heartburn and regurgitation. There are also many others, including chest pains, dental erosions, bad breath, nausea, difficulty swallowing, pain when swallowing, laryngitis, and finally asthma, as the acid can trigger bronchospasms. Diagnosis is usually based on the classic symptoms, as well as response to acid suppression medication. There are also other procedures to identify this disease, which include endoscopy to view mucosal damage and probe monitoring of the pH in the esophagus. Risk factors of GERD include older age, obesity as this increases abdominal pressure, smoking, stress, and reduced physical activity. The eating habits of individuals, including the acidity of food, size of meals, and timing in respect to sleep, also contribute. As many of the risk factors are lifestyle-related, reversing these in lifestyle modification is the first component of managing GERD. This includes weight loss for obese people, avoiding meals 3 hours before bed, and elevating the head while sleeping to reduce the opening of the sphincter. Diet modification is also a possibility, however this is controversial and is not routinely recommended. Medical intervention is also possible with antacids, which neutralize stomach acid, anti-secretories including histamine 2 receptor blockers, and proton pump inhibitors, which decrease the acid production, and prokinetics, which increase sphincter strength and cause the stomach to empty faster. Finally, if other treatment fails to alleviate symptoms, fundoplication surgery can be performed to strengthen the sphincter. This is done by wrapping the fundus of the stomach around the esophagus.